Hello again. I know every branch in medicine is doing a significant improvement in the treatment of the diseases. In last several years, as far as chronic lung disease, COPD, related to the smoking is concerned, we have had some improvement. But sometimes I feel like we have the old wine in the new bottle type of things. We have gotten several new inhalers, but unfortunately, other than similar type of reaction, nothing much has happened as far as these inhalers are concerned. There are a couple of new treatments in pipeline as far as medicine is concerned. But several years ago, the surgery called volume reduction surgery was started. Through a small incision in the chest, the blisters on the lungs or the bullae were cut out, and that gave the healthy lung or so-called healthy lung to expand and improve the lung capacity. That was called surgical volume reduction surgery. And as much as you can talk about, it was a major surgery, so people had to undergo anesthesia, have a cut, and then do it. Since then, the technique was approved by the Senate committee, and it has been done, but kind of a limited way. A lot of thoracic surgeons still don't do it unless it is a big blister, like a few centimeters, and is compromising the lung capacity, or there is fear that it will collapse, it will burst open and collapse the lung. So in recent past, maybe last 5 years or so, a new technique of putting in a valve through a bronchoscope has been developed. There are two kinds of valves that are approved by the FDA. And these are valves called bronchoscopic volume reduction is what is the term that is used to use these valves. So there are two kinds of valves which are approved. Both of them have a little different appearance, but the success is similar, and the reasoning behind putting these valves is same. If one can think that if you would take a breath in fully and instead of letting out the entire breath out, you stop and keep some air in the lung and then try to take another breath. As you can imagine, your breath would be smaller and the shortness of breath will occur. Due to hyperexpansion, the lungs are inflated beyond their normal capacity, and the emptying of the lung is not complete, so amount of the air that remains in the lung is increased. This is what exactly happens in emphysema. And when it reaches to a point where forced exhalation leads to narrowing or collapse of the small bronchial tubes called bronchioles, more and more air gets trapped, and then the alveoli becomes dilated or bigger, and that retains the air, and that causes more shortness of breath. Of course, if this gets to a point where the other lung tissue is affected or compressed, then shortness of breath increases. So there are a couple of terms that I'm going to use, and I'll explain it to you briefly and quickly. When we measure the lung capacity, the typical thing which is done by average physician is called what is the total amount of air that you can forcefully exhale, and that's called force vital capacity, FVC. Then there is a measurement called how much can you bring out quickly, which is in 1 second. So since it is in 1 second, it is called FEV1, force expiratory volume in 1 second. And the ratio of this becomes abnormal in people who have asthma or COPD. And then that's the amount of obstruction in the bronchial tube that we diagnose. Now, there are other measurements that are also done in the offices of lung specialists, usually not in the average allergist or average family doctor's offices. That's called measuring actually the amount of air that is in the lung. So the total amount of air that a lung contains is called total lung capacity, TLC. And then we also measure another number called residual volume, or RV. the amount of air that remains in lung after you have completely emptied the lung. As you can imagine, in emphysema, the total amount of air that remains in the lung, called residual volume, is increased, and total amount of lung capacity, TLC, is also increased. So these two measures indicate that there is a retained air which is not emptying the lungs, and that causes more shortness of breath. So the idea came into the existence that if we allow the alveoli to empty completely, or at least get rid of this retained air, then the shortness of breath and the pulmonary functions of the lung capacity will improve. And that has been documented with the bullectomies, or the volume reduction surgery that surgeons were doing it. So now the technique has been practiced to some extent, improving, but perfection and approval has occurred, where in selected group of patients, and again, I stress the word selected group of patients, when you put a one-way valve, the valve that allows the air and the mucus to come out from this hyperinflated, increasingly inflated lung tissue or alveoli, but does not allow the air to go in. When that happens, that part of the air, that part of the lung collapses or becomes smaller, and that increases the compliance of the remaining lung, and the shortness of breath improves. So this technique has been now approved. There are 2 approved valves that are available. Zephyr valve is one of them. And whenever these valves are put in a select group of patients, then they do seem to improve their lung capacity as well as shortness of breath. And on a long-term follow-up, 1 year to few years has been now coming into picture. These are brand new techniques, so we don't have a long-term data. Now, so the criteria to select the patients is based on just the physiology that I just mentioned. Number 1, somebody must have a good amount of COPD. That means it should be at least severe. The number that we talk about is FEV1 of less than 45%. Amount of air that an average person of same age, normal lungs, would exhale. If the patient's flow in 1 second is less than 45%, that is one criteria. If it is less than 15, you're not a candidate because that's the disease is too severe. The amount of air that remains in your lung must be increased, and this is total lung capacity must be increased, and so must be the residual volume, the amount of air that remains in the lung after you have fully expelled the airs. So those 2 criteria, those 3 criteria are based on lung capacity. Additional criteria are based on blood oxygen, carbon dioxide. If somebody has a carbon dioxide which is greater than 60, normal is less than 40, then he will not be candidate. So up 40 to 60 is fine, 40 to 50 would be good. And lastly, but not least, is amount of ambulation that you can do should be at least greater than 300 feet in 6 minutes. Again, please remember that if there is a evidence of a pulmonary nodules or lung cancer or scar tissue or significant heart problems, then these techniques may not help that much. There is one additional thing that I will leave you for today to talk about, something called collateral ventilation. Collateral ventilation is one part of the lung communicating with the other part of the lung without going through the bronchus. And so that is based on the fissures of the lung. Fissure is like you have a segments of the lung, upper lobe, lower lobe, and the middle lobe. On the right side, upper lobe, lower lobe, and lingula on the left side. These are separated by a fissure. And if those fissures are incomplete or they allow the collateral ventilation to occur, then these patients will not be benefited by valves. So that testing is done based on high resolution CAT scan as well as a technique which is done when people undergo a bronchoscopy to have these valves done. So when the valves are put in, prerequisite criteria are based on absence of other problems like new nodules, scar tissues, heart problem, bad enough lung capacity, but not bad enough that they will not be benefited. And there should be absence of collateral ventilation. So I'm just going through grossly. Individual patients would be evaluated by interventional pulmonologists who do these things daily. And then there is substantial benefit that can occur if these valves are placed. There are complications that can occur with these valves. Maybe we'll talk about that some other time. Thank you for watching. Have a nice day. If you like it, please subscribe. Thank you.